Good evening, everybody, and welcome to our webinar tonight. Before we go any further, I would like to acknowledge the traditional custodians of the lands we walk, reside, and work upon. We pay our respects to First Nations people and value the continued connection to culture, country, waterways, and contributions made to the life of our vast region. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Welcome to our webinar, the Workforce Incentive Program Practice Stream webinar series. This is part 2. And the topic tonight is empowering multidisciplinary teams for enhanced patient care. Tonight we have Simon Ashley with us from Attune. Simon is an osteopath and is the CEO of Attune. We also have Dr. Michelle Redford, who is a GP, who will be facilitating our Q&A session, which will be at the end of the presentation. We also have Dr. Kim Liu. Kim works with the RACGP. She also works at Riverstone Family Practice, which is in northwestern Sydney. And she's also a GP lead at Wentworth PHN. So it's great to have someone from another PHN with us tonight. Please don't hesitate to put in any questions in the question box, type them in, and we will cover them all at the end. This session is being recorded and will be available in our library from tomorrow, along with a PDF copy of the slides. I think that's all you need to hear from me. Kim is going to speak. So I'll just bring up her slides and we can get started.
Hi, so I've been in general practice for over 30 years in Western Sydney, in northwestern Sydney, where I can see this. So this is the practice. It's Riverstone Family Medical Practice. We have built it from the owners. One of the GPs at our practice has built it from ground up to be sustainable. So we've got the solar panels on the roof, and we've got a battery to power the practice if the power goes out, instead of using diesel generators. And the whole place is thermally efficient. And you can see the double glazed windows there. We've also got a water tank to flush all the toilets in the practice. And we have a practice with about 12 GPs. We've got 3 registrars and medical students as well. The point I bring up about this is that it's so important to look at the way we build the structures around the practice, and it's a good example of what can potentially be done. Next slide. And this is our practice, not everyone in the practice. So we've got the practice doctors, nurses, some of the registrars, and one of the medical students in this practice. And we do work collaboratively and cooperatively, and we try to maintain a respectful workplace where we're all kind to each other, which makes it really a pleasure to work there. And it really is understood when anyone is employed in this practice that we understand that we work as a team, not as solo agents. Now, we know that with general practice, it can be so complex when we actually are seeing undifferentiated, sometimes uncertain, uncomfortable, unremitting presentations, where sometimes there's a dissonance between what patients want, sees the outcome, and what the doctor does. And general practice is not the transactional general practice. We need to look at the whole person and its continuous care, look at the breadth and depth of scope. It is cradle to grave. We have continuity, accessibility, inclusivity, and we also have to have the capacity to actually see people when they have complex presentations so that we can explore the underlying issues. And, it is really hard to work as a solo GP dealing with all this complexity. That's why a teams-based approach is so important. Next slide. So I have nicked this from another organisation because it actually shows the teams-based approach in a way that is easy to see. So at the core is the patient and their caregiver and loved ones. And the team that looks after the patients can move in and out of the inner and outer circle depending on the patient's outcome. So with our patients, the primary team who look after the patients are the doctor, and all of our patients have a secondary doctor, and also they are attached to a nurse. So there's continuity of care. So because we have 3 registrars at any time, patients who are looked after by the registrars don't have the continuity if they're not attached to a nurse. So optimally, we want that to happen. And also the reception staff as well. So within Wentwest, working with Wentwest, the other teams that we integrate with and work with is our pharmacy program. So with our care plans, we have the DMMR, where our pharmacist actually goes to the home of our patients, looks at their medications, and looks at how they're stored, how they're taken, explains to the patient why they're taken, because it's really common that patients lack compliance with medications. I've found that using our pharmacists has actually improved the care of the patients because there's a deeper understanding by the patient for compliance. And in terms of psychosocial and psychiatry support, Wentworth also engages an NGO called Flourish. So my more complex patients who can't afford to see a psychiatrist see a psychiatrist who comes to our practice with a social worker or peer support worker. Because within Western Sydney, we actually have it, and I'm sure with the Hunter New England, we have a growing number of people with really complex disease, social circumstances, and living in poverty, with food poverty, energy poverty, in really insecure housing. So the psychiatry and psychosocial support is so important. And in terms of the diabetes team from West, we also do consultations where we actually have, and diabetes is so common within Western Sydney. Something like 15% of our patients have type 2 diabetes, and there's a mass of others who are underdiagnosed or pre-diabetic. So the team that helps with the diabetes is usually, we see them on a platform where we see the endocrinologist, the dietitian, and the diabetic educator with my diabetic nurse, as well as the patient. So my more complex patients I have to manage can actually be managed by me with the help of the diabetes team, seeing me and my patient every 6 months, depending on how severe my patient is. And in terms of heart failure, there is a heart failure team that is with the hospital that we connect with Blacktown. So my poorer patients are also seeing the heart failure team, and that they communicate well with us. So the team doesn't have to be in the surgery. The team can be part of our patient care with good communication. And then we also have our physiotherapists, and we're about to have a dietitian. So depending on what the patient has, all these teams move in and out of the inner circle. But the main thing is continuity of care and communication. And so in terms of the spaces where I don't have a continuity of care is with my NDIS patients. And we're trying to look at ways that the allied health who look after my patients on NDIS can improve their communication with me. And running a teams-based approach requires everyone to understand the teams-based approach. So what I have is that all the allied health and specialists who work within our team, we can also easily contact. So we have their emails and mobile numbers, so that in case if circumstances change and the patient and information needs to be communicated, it can be communicated easily. So we try to really simplify the direct communication between the teams. And so I've worked in this practice since 2017. It's a lot of hard work, and really everything runs on the shoestring because all the money made is paid to staff. We would love to have more nurses. We would love to have a social worker who works in the practice, but that all requires a lot of work to try to better resource our team, and the areas of advocacy are to actually move practices, because we've got 6 practices that work in this way within Wentwest, and we have 6 practices are sort of graded into 6 levels. So the number 1 is the transactional practices, and number 6 are the 6 practices that run like the practice I work in. So it's to actually sort of step up other practices to try to achieve this model because it optimizes the care. And the other thing we try to do is optimize high value care, so to minimize low value care. So we do talk about this in the practice. So high value care is really doing all the housekeeping we do to keep all our chronic patients. So I call it housekeeping with my patients because, having a diagnosis of diabetes or heart failure can be really devastating. But if you actually talk in terms of the things you have to do to keep well, like housekeeping, I find that patients manage better. So, so that's the end of my presentation.
Thanks very much, Kim. That was great. If you just give me a few minutes,
Yeah.
I'm going to make Simon a presenter so that he can share his screen. Great,
Hello, how are we
Simon.
going?
I can see your screen if you just want to start your slideshow, and we'll be right to go.
Absolutely. Wonderful. Can everyone, whoops.
No, that's great. Thank you.
Yep, that's all working. Wonderful.
Yes.
Hi, everybody. As you heard, my name is Simon Ashley, and I'm the CEO here at Attune Health Centres. So it's a great privilege to be here today and to be able to share a little bit about how we do our integration and working together. For me, this is not just a good thing. It actually is a passion. And I started Attune because when I was 19, I had a near-death experience, and my experience through the hospital setting back then really showed me that integration could be done a whole bunch better in our health profession. And so I sort of had a bit of a vision of building a centre that brought about everything all in the one location. And as you can see here, this is our building here at Attune. So we have 2 premises. This is one of them. The other one's not quite as big, but basically this is a purpose-built building to actually able to provide an integrated service for our clients, because we have found that having everybody all together, all working together, is really critical for the well-being of that journey, as you heard before. And so for us, having that one-stop health centre has been a game changer, I guess, for our clients. And really, when it comes to the building, as you can see, there's lots of centres around that you may have seen that are big, what they call super centres. And those super centres, essentially, the model for them is somebody will build a building, some investor will build a building, and then they'll lease out the space to whoever is willing to, pay top dollar or to utilise that space. But there's really not continuity of care in the business model. So you've got a whole bunch of businesses doing their own thing. There might be a little bit of crossover, but to actually have a business model, not a building model, that's what we talk about. Everybody who works in our building actually works for Attune. And so therefore it allows us to be able to coordinate the care. And so the case study that I'm going to show you in a moment basically sort of showcases how we do that. and I'm happy to answer questions on how we actually navigate. There's lots of problems and lots of obstacles around doing integration well, but we also see that there's great value in it, and research would say that you have 70 to 80% better health outcomes for your clients, and there's also a better diagnosis of your client of around about 60%. Some research now is starting to indicate that, when you've got a team of people, the diagnosis is better, and then the outcomes are better. And the reason the outcomes are better is because the client is compliant. They don't have conflicting opinions. They feel like they're heard by multiple people. We're all on the same page. And so their journey through the healthcare journey that they have is actually a lot smoother. And they're much more compliant because there isn't confliction. There isn't uncertainty about what is happening. They feel confident about the journey that they're on. And actually that in itself is healing for a lot of our clients. So to give you an idea of what we have in the building, it's a very big building. So we have about 120 staff all working in Attune at this present, and we have all those modalities. So we actually have 18 health modalities, if you like, that all work from the building, all working together. And so we have, the physios, the psychologists, the osteopaths, massage. You can read them all there. We have several medical specialists as well. And we have, for example, we have naturopaths working with our GPs, working with all our team. We actually have an acute herbal dispensary, which is free service. So you can walk in, you can find out about, what your medications potentially might interact with some of the different natural alternatives, and actually gives people a really good confidence in, okay, well, this is how I can navigate some of these things into the health condition that I have when they're seeing their GP or so forth. The other thing is that we're not GP-centric. Everybody will triage. Now, we're not diagnosing, but we are able to then, if you come in and see a psychologist or come and see a physio, and actually you'd be better seeing an osteopath, our team will basically triage the clients that come through the door so that they get the best place for them. Because everyone thinks that they know what the right thing is, but we sometimes recognize that actually that is not our scope. That's probably not the best thing for us to be doing. Maybe if you go over here, you're going to find a better solution for your care. So this is the model that we have. As I said, it is a business model. It is not a building model. So the client is center, and then everybody plays their part in the care. And when it particularly comes to non-acute, more chronic type illnesses, what we have found is that 80% now of what it is that we're seeing in the health is because of lifestyle impact. And so we need to be addressing lifestyle, and you can't address lifestyle without actually having an integrated model. And so the client is the center, and then there is all these, if you like, spokes off the wheel that we can potentially touch base or connect with to actually provide that better lifestyle outcome for that client. And so we've got the EPs, the podiatry, the dietetics, the naturopathy, all of them have their place in that integrated model. And the only way to actually make it functional and like a wheel is if we are all on the same page working together. And so it has to be the business model, not the building model, that truly does bring about a much better continuity. So the case study that I wanted to share with you that I want to talk about is a popliteal artery aneurysm. Basically, it was a multiple team approach to this condition, and I'll just go straight into it. So basically, the client that came in, they had diabetes, but they also had a left knee reconstruction. And so what had happened is they got a complication from that knee reconstruction, which was a popliteal artery aneurysm. What this whole process, and I'm going to go through it bit by bit, highlighted how integration and working together was such a critical part, and how we were able to come to a very quick diagnostic conclusion, and it saved the client a lot of ongoing problems. So she was a female client in her early 70s. She had a BMI above 35, which is important. She also had type 2 diabetes, had arthritis in both knees, but the left one was a lot worse. She also had hypertension, was quite obese, and had basically started metformin, but had an intolerance to that, and so had stopped it on her own accord. And she also had a very sedentary life. So she came initially early on in 2023. because of the diabetes diagnosis. And so we were able to get her straight away in to see a dietitian and our exercise physiologist, and we began a program where we were able to support her in that new diagnosis of diabetes. We were able to help her with her weight loss as well, get her moving, get some more functional independence through some of these programs that we were able to run. And the doctor and the dietitian and the EPs were able to work very closely in supporting this woman get going bit by bit, because as we know, when they haven't done much, it takes a bit of time, but we know the value of doing those things. So then what happened is we basically recognised that she needed a knee reconstruction, and so she was referred for that. But because of the delays with the insurance and that type of thing, it actually was a good thing. Sometimes delays aren't a bad thing, because it gave us an opportunity to do some physio, to do some optimization of that knee, to maybe get her weight better, get her mobility better. And so basically we were able to optimize her musculoskeletal health and also her diabetes as well. And so by the by the early 2024, we had actually normalized her diabetes. So she was back to within normal range through the programs that we'd been able to put her through. She'd reduced her BMI to 33. And so therefore, all of these things, plus having a more active life, meant that her knee reconstruction, she was actually going to have potentially a better outcome, because she was a little bit healthier, she was mobilized and moving better. And so then she had the knee reconstruction in May, on the 8th of May. And then very soon after, she developed left sciatic pain. Or that's what she described it as. And she had ongoing pain and foot numbness as associated with that. So that would very much indicate, being a manual therapist myself, that potentially there is some sort of, sciatic nerve involvement or some sort of back involvement. She also had worsening neuropathy, and so with with the physios looking at it, there wasn't anything that really indicated anything coming from her back. She had no back pain. She had nothing like that would indicate that she had a back problem. But we still went forward with an MRI, which indicated, yes, there was no pathology in her back, which was causing her problem. And again, this is very much working collaboratively with the GP. We're talking, we're saying, well, this doesn't quite fit the normal, but let's just, do this one step at a time. So we were able to progress her through very well. But her symptoms continued to worsen. And in September 2024, she was actually seeing a massage therapist to help her out. And the massage noted a significant change from 1 week to the next, that her legs started to change in color. It became a lot more asymmetrical. It was becoming more motley and was much swollen on the left than it was on the right. And so there was a vascular concern that our massage therapist had that she was able to bring to the GP. So the GP was wanting to investigate it further, because there was no significant pathology that we had discovered. The lady was wanting to go overseas. So she actually said, I'm not going to do any more investigations. I'm sorry, I've got a trip planned. Everything seems to be the way it should. I'm going to go overseas. So she went overseas. But by this time, her BMI had gone down to 31.5 and her blood pressure had actually normalized as well through the programs that we had been able to assist her with. So then she returned from her overseas trip in March. Wouldn't we like to have a 6-month trip around the world? That would be amazing. But so anyway, she came back and basically the GP said, look, we probably need to do a podiatry assessment because we haven't done a podiatry assessment for you for your diabetes anyway. We think it's probably not a bad idea. So our podiatrist had a look at this lady and she noted the edema. She noted the purple motley left leg. The sting integrity was intact. The neurology was normal. However, there was a vascular sign on her Doppler, which basically was a monophasic waveform on the left. Now, I don't understand that completely because I'm not a podiatrist, but what my podiatrist explained to me is when you have a waveform like that, it could be considered normal, or because it was a little bit monophasic, it could be considered abnormal depending on symptoms. And because she had some swelling and she had some purple motley on the left leg, the GP and her had a chat actually just in, and that's the beauty of being all in the one place, had a chat in the staff room one day, and they talked over this client for 5 minutes over lunch. And they basically did a hand back over to the GP to investigate further. And so the GP got an ultrasound, and if the ultrasound wasn't good, they would have done a Doppler. But basically, the ultrasound came back and indicated there was a popliteal artery pseudoaneurysm. And so therefore, they went for urgent surgical referral to get this corrected. And basically, the surgery was very successful. All the symptoms basically went away, and the patient reported significant relief from that surgery. So for us, basically, this happens often, the misattribution of symptoms. Sciatica versus diabetic neuropathy versus, an aneurysm. Like, all of those things were in play. And having the team to be able to look at this and discuss it, the person didn't carry on a long journey, even though they went overseas for 6 months, which was just the way that happened. But in terms of the clinical, it was very much, we were onto that. We were discussing the different things, what needed to happen. And it was the multidisciplinary approach was key to actually getting the resolution quickly and successfully for the client. So basically, for us, what we recognise in this is there's so much in this, because they had diabetes, they had high blood pressure, they had a very sedentary life. So our EPs, our physio, so most people in some degree were involved. And it's not about getting people involved in the care. It's about getting the appropriate care for that client for their needs. And so, having the massage therapist, which basically, was seeing her on a more regular basis because that's what she liked. She wanted that. That wasn't necessarily, you need to see the massage therapist, but she had a relationship with that massage therapist. They were able to pick up quickly that something wasn't quite right here. And being able to talk to the GP really was a real great confidence for her in knowing, okay, well, maybe there is something going on here. We need to take this further. And then getting the podiatrist involved with the GP to finalise the diagnosis of the artery was basically, again, they were working together closely. There wasn't lost in translation what was needed, and they were able to come up with a diagnosis and therefore resolution to that lady's problems very quickly. And so that's basically our little case study. And basically for us, that's very much highlights Attune in a nutshell. We have clients every day. I've got hundreds of case studies like this where people will come in and we're able to piece apart and able to give them and help them with the best care that we can provide, with multiple heads, with multiple expertise, all coming together. And I just wanted to read a comment that my GP, she said, when we were looking at this, and I wanted this case study as to use for you guys tonight. She messaged this to me. She said, look, thanks so much for looking at this case. I really appreciate it. I've really enjoyed being at Attune. And she said this: it is really hard to relay as a doctor just how much the small comments and conversations I have in the corridors and the tea rooms generally shape and guide my clinical decisions. It's like everyone adds a piece of the puzzle. Sometimes they fit straight in and I see where they go. Other times they are pieces that go somewhere I wasn't quite up to. But I have them there in my consciousness, means that when other things start to show up, I can more quickly and accurately take the next steps in the clinical care pathway. Better, quicker, and more accurate referrals and outcomes for clients ensue. And that's what I love about the way we work here together at Attune. So I thought I'd conclude with that comment from our doctor that was involved in this particular client. And back over to you, Jenny. Thanks so much for listening.
Thanks, Simon. That was a great presentation, and as was Dr. Kim Lew's. We haven't got any questions typed in yet. I know somebody did have their hand up earlier. I'm just going to, Tian, ask you to unmute so that you can speak and ask your question if you like.
It's fine. That's okay now.
Oh, okay. Were you having trouble with your webinar?
Yeah, well, I just have trouble logging at the beginning. I'm okay now.
Okay. Um, any other questions that would like to come in?
I've got some questions, Jenny, if I
Great.
can take it. Maybe Dr. Kim could turn your camera back on and we'll be able to see both of you. Thank you both for your presentations. That was great. I suppose I'd like to start with what you see as some of the barriers you've identified to effective multidisciplinary team care. You know, not everybody is working in this way. What do you think some of the barriers are? Would you be all right to take that first, Kim? Thank you.
Yeah, sure. I think because the other space I work in is also I work with the Council for the Aged, and I spoke on their panel about teams-based care and the lack of resources in country areas that are more distant than our PHNs, where they don't actually have the resources to do the team-based patient-centered care. My patients realise that they're really lucky. We're sitting in northwestern Sydney, where we're surrounded by allied health and specialists. And so it is easy for team-based care because the teams are close. Even though they're not necessarily in the same building, they're just like a 10-minute walk away or a 5-minute walk away. So
when we're talking about resources, you're talking about
like
the
allied health
personnel
and medical personnel resources.
Mm.
And it's how can we actually have the same team-based care in more remote places where they just don't have even the doctors.
And sometimes when we're talking about resources, we're also talking about funding. Do you see any, like, is that an enabler for team-based care? Is there, do you find?
It's also the work staff shortage of general practitioners. I mean, there's 40,000 general practitioners within Australia who are part of the RACGP. We're increasing, there's more funding for more places for general practitioners, but even just getting us. And this is why part of team-based care is you actually, the way I see it is that you have the doctor who actually connects with everyone on the team with the patient. And so that you have other practitioners who help with the housekeeping. Like you said, Simon, okay? It's the housekeeping, and when acute things come, you have people there to physically manage. It's even getting allied health in remote places. And I sat in that, it was a very large audience of over 65-year-olds who came from all over New South Wales to that panel meeting. And you feel powerless because there is the absence of workforce in those regions. And, it's the funding of healthcare as well, is that the funding is for transactional care. If you're going to make a lot of money, it's transactional care. And you don't, transactional care is not good for preventative care, where we have got so minimal funding. So it's looking at the spaces where we can increase primary care. And primary care is not just general practice. Primary care is a broader team so that we can reduce the amount of people going into tertiary care, which is the expensive part of care. We're the cheaper part of care.
Thanks for saying that, Kim, about primary care is larger than general practice. And Simon, what would you see as the barriers to effective multidisciplinary team care?
Yeah, look, I would definitely say funding is certainly one of those. So, doing it effectively, joint consults, other things like that are great, but, trying to line them up and actually get funding for particularly the allied health part of things, that's only a new thing, and they still aren't very funded very well. Look, the medical software that we have is it's very hard for the software to talk to one another. There are a lot of barriers between communication that we find. So we have to still do the formal letters and things, which are great and they're important. But there's other ways that potentially communication could be could be more effective if software was able to speak to one another and that type of thing, particularly in our setting, in the building that we have. I would also say that the hierarchical structure that the medical profession tends to have can be a barrier. It can be very good as well, and it's very important when there comes to an acute care. You certainly know who you want in a particular situation. However, that can also be a barrier in the fact that some people may not speak up about a particular thing if there is this hierarchical structure. I have all the answers, or I control everything, and that sort of squashes, if you like, other people maybe working together. So I find that that cultural thing, as Kim was talking about, that everyone works together. They know that that's the key thing, part of their team to make that work. That's so important when it comes to a multidisciplinary team. If everyone is willing to listen and engage, and we have some amazing meetings where everybody's inputting, and so when they feel they can all contribute, it's amazing what we can all learn from each other. So I find that that's certainly something, and I think it's also the training. There's a bit of a silo mentality still out there that what we do is the best, which absolutely what we all do, but we got to understand there's a scope of practice that we all have, and sometimes we move outside our scope, feeling we can do everything, and that becomes problematic when it comes to actually getting good care. So I think that training and that how we educate our students is a significant part of potentially a barrier in the mindsets of people working together.
And
Thank you.
also think, well, it's the continuity. I mean, I suppose with general practice, I've seen some of my patients for 30 years now. And so the trust factor is there as well. I mean, so much has changed I graduated 36 years ago. So much has changed in the last 30 years in terms of what general practice sees itself. I mean, still solo practitioners who struggle during COVID. So, as a GP, I find I enjoy team-based care. It's how you actually, and we have students, and they can see that teams-based care really nourishes all the people who are actually in that team, because you support each other. Because it's hard yakka being a general practitioner. And yeah, I'll stop talking there.
That's great. So what I'm hearing from you both is maybe some of the enablers. So I think I heard something from you, Simon, about maybe people are not all using the same software within the same team. Is that right?
Yeah.
Okay.
So basically,
Yeah.
specialists have to use their own particular software. GPs have your own software to do your scripts and other things, which really doesn't cross over into some of the allied health professions. So there's specific things that they require. So none of those talk, and so therefore we often find like reports might go to the GP, but then it doesn't get sent across to us unless we get it sent across via medical objects or other mechanisms, and so it just makes it a bit clunky in the background.
So that would be a key enabler, like having the same software or shared software, or that kind of digital enabler. And I think also, Kim, you mentioned about continuity of care and that key concept. And we know that continuity of care, the evidence is there, isn't it? It keeps people well and out of hospitals. So that sounds like another kind of key enabler. And then the other thing I've heard from both of you is that team building. How do you invest in the team? How do what steps do you take within your organizations to build the team?
Okay, with us, it's clinical meetings once a week. So we all sit down together and nut out any clinical problem or problems with process that arise. And that's really valuable because everyone in the team, including our most junior reception staff, feels heard. And so we also have regular things where we actually have lunch together, or we go out and do something social together. The whole team, there's about, I think once we actually add everyone up, there's like 40 people there. So it's so that we show that we value each other. It's not just a workplace, it's a community.
Yeah, so that comes back to that theme of trust, which I think you both touched on, and that kind of valuing other people's roles and contribution and experience. What about you, Simon? How do you build teamwork and build the team?
Yeah, so there's a few things that we do, and I think for me that's probably critical. When you've got 120 people working all together, team is vital. And so it's who we pick and who we allow into the team, I think is probably one of the most important things. So I've said no to as many people as I said yes to. And look, medical people are as rare as hen's teeth in some degree, like GPs particularly. But if you get a bad egg, it just ruins the lot. And so we have found that, it's very important who you get and you select into your team to allow that team. So if they're passionate, they want to see integration, they're willing to work with others, that's a great start and you can work with that. But if they're not, then that creates a division straight away, and we don't want that within our team. Healthy conflict. So we talk about actually how we ask questions. So we are going to disagree. How do you disagree in a healthy way? Well, it's about not saying, "Oh, I don't agree with that. That's wrong." It's, "Oh, okay, explain more. How does that work?" And then that allows us to be educated in potentially areas that we're not aware of. And all of a sudden we go, "Oh, wow, that's really interesting." Or we get to a place where we can actually agree to disagree. And that is okay as well, because we agree with so much more than we actually disagree on. And we talk about that quite often, is that, we're not always going to agree on everything, and that's okay. It's about the well-being of our client. And as long as, we're talking about it and we're working out what the best pathway is, there's a lot more healthy way of conflicting things, which, that's a work in progress. Everyone does conflict very differently. But if you model it well, and it's part of who you are, then it actually allows for a much better team environment and therefore collaboration. Look, we have clinical training where we basically talk out different cases. We all get together and we workshop it. We do case studies, that sort of thing. We do that on a regular basis. We also get different departments together and they do their own little workshopping to develop that, connection. And that really comes back to that whole trust thing. Is trusting one another and trusting their clinical judgment. So when we do refer someone, we know exactly what we're going to get, and that comes a little bit with me understanding and actually learning the different things, and so taking that time, and we encourage people to do that, because otherwise, that does break down the integration a little bit. And the final thing that we do that's probably a great thing is we have what we call soft handovers and hard handovers. And so to build really good teamwork, we have formal letters, but we also have a whole bunch of different ways that we do what we call soft handovers with clients, where we can be connecting with other profession to actually, again, you're building teams, you're building bridges between professions, between each other, so that you can actually have we talk about, a bridge that's safe for the client to cross. And so they're all sort of some of the things that we will do to actually build great team. And it really is a lot of work, and it's a very important work when it comes to multidisciplinary.
I am aware we have just got a question. I do want to go a bit more into enablers. If Kim, you have any other thoughts about team building and enablers?
I kind of want to also mention with it's the social infrastructure around the practice as well. So with us, we have the men's shed, the community garden, the local Northwest Community Services, which deals with all the social problems within the area, community pool, and so that, and they are part of the team as well, the local social infrastructure. And we're just so fortunate to have our practice right next to it. So you can see it from our sort of second floor of our building. And social infrastructure is so important to build in communities with practices as well.
Do you have like a social prescriber or link worker?
Oh yeah, look,
role?
I do. So we do social and nature prescribing. So we know the walks and green spaces around the area, because there's so much evidence for nature prescribing and social prescribing. The evidence is there now, and more for nature prescribing.
But it's not a dedicated role. It's something that everybody is engaged with.
Well, I teach the registrars and the medical students to come through because, and also because I do a lot of nature and advocacy as well. Like, we're losing our natural spaces at a phenomenal rate through New South Wales and Queensland, and we need general practice in this area. There's universities working in this space as well. But this is aside from tonight. Sorry.
I will just go to the questions. There's a question for Simon. Thank you for putting your questions in. So, does Attune Integrated Health receive referrals from outside GPs? That's the first part of the question. And then, does the quality of communication impact care to those patients? So your comment about the GP conversation in hallways is telling of this as a barrier. So I suppose it's, if you've got an outside GP referring in, how do you then communicate and work still in a team, but in a not co-located way?
Yep. Oh, look, absolutely. We love working with other GPs, and I think that's a really important part, because it's not about our GPs, it's not about our building our micro. It's about us working together, as a health community. And so if we can contribute to that, that's important. So of course we can't do soft handovers with those GPs, but we try to build relationship where we can, and we'll certainly try to communicate with letters in that formal way. And if we can, like we often do, GP meetings where we go and actually try to meet the GPs at other clinics, and some of our team come along, just to be able to meet people face to face is really, really important. So we try to make the effort to do that on a regular basis. We don't always get through the door. People aren't always interested, and that's okay. But we try to do what we can to connect with those doctors and also specialists. We've got a lot of specialists who send people to us, and again, they're really important referrers, and we want to be able to support them. And so we will always communicate to our GPs or specialists. One of our rules: we do not send anyone to anybody else apart from going back to that GP first. In Attune, it's a little bit different because our GPs understand. But if a GP or a specialist send any client to us, we won't refer them on to somebody else in our business unless at first we've spoken to the GP and get their approval for that. So now, in saying that, some clients will just do it on their own volition. That's up to them, but we try to be very respectful for every person that we engage with.
So what would your messages be to other general practices? I mean, we're focusing a bit of on general practice because this is in the WIP PS series, and so that is a workforce incentive program for general practice. So, it's not to say there aren't other ways of working, but just for the focus. Kim, what would you say to other general practices? How can they get started with working in a more multidisciplinary team way?
We have processes within Wentworth where practices get practice visits to enable, especially with a lot of the solo practices or smaller practices, to try to actually improve their training regarding the processes in place to improve areas of communication. And so the PHN is just invaluable to help people be more integrated with the systems around, so that we actually improve their communication. So I think PHN. I mean, also even practice visits to practices that are already running on the basis of multidisciplinary care is useful, and that's why having medical students within because we take the Notre Dame students from the Hawkesbury, and they go to different general practices at different stages of development, and they can see the differences between the care between a transactional practice and a practice that practices high value care. And it's what people experience as well. That's why it's good that registrars go to different practices and see how they all run. Because once you see, and patients actually tell me, we come here because we can see the care. There is care. It's very hard to care for someone if you see them every 6 minutes. It's how you want to work and live. I mean, it's my vocation. So I want to work where I work with like-minded people. So, yep.
What would you say, Simon? What would be a first step if you were trying to become more multidisciplinary as a practice?
Look, I would say build bridges. So how do you build a bridge? Well, you start building one way, and then if you find someone who starts to build back to you, then you start to build a relationship. So if you are a solo and you don't have anyone else, building the team network. So having your team, if you like, of multi. So and I'm sure most doctors would have that in their repertoire. I know that this is the types of physios I want to go to, and these are but getting to know them a little bit and actually reaching out, because I can guarantee you that any allied health that you reach out to would be more than wanting to connect back and workshop clients with you, because I know from the allied health perspective that, we want to value and work with GPs. And so doing so, I think, would help start that process. And then, or the other way that I'll go is, what are the areas that you see, of need in your clinic that you go, it'd be fantastic to get a dietitian, and start looking, go to the PHN, and start building connections with some dietitians and seeing what you can actually, how can you bring a dietitian into your business? Recognizing, and this is probably really important, that they're not going to be like a GP. And so the way you engage a dietitian or a physio or an allied health isn't the way that you would engage in a GP. And so you need to try to tweak that model to actually accommodate their needs a little bit, because they're not going to be able to fit into that, into the mode that the GPs are used to working in. And I guess I have the great benefit of seeing GPs work and seeing all the different professions, and I understand their different needs and wants, and recognise that you have to be flexible to allow them to integrate in. So I would just pick one and start with one, and have a vision for what that looks like, and really, and go for it, because I honestly think it's the way to go.
But I'd say something really quickly. Continuity of care also means continuity from tertiary to primary. So when people are discharged, and that's improved in Western Sydney. So as soon as a patient goes to the KISS Hospital, Blacktown or Mount Druitt, before they leave, I get their discharge summary. So I know they've been there. And I mean, there's areas that need to be improved with people leaving with domestic violence. The communication is not great when they leave hospital within that space. And NDIS is still a problem. Maybe we've got a new minister for NDIS, because it's the allied health and NDIS just do not communicate with me unless I chase them.
And so that transfer of care between a hospital setting and back into the community is an ongoing focus, isn't it, of advocacy?
It is, because people die in between. So it is an ongoing advocacy that we've been doing for years in Western Sydney.
And how do you think we advocate more widely for multidisciplinary team-based care?
It's funny, do you know the scope of practice review that the federal government did?
I do indeed know the scope of practice review.
Yes, because I spoke about multidisciplinary care at that review, and it's really showing that there's good evidence. I mean, you look at Lumos and any other area that collects useful data, and you can show that there's improved care and improved outcomes with multidisciplinary care. And so it's really seeing the politicians who make the decisions, and a lot of them haven't received good care, as in they haven't received care. Because I do ask, because I've been doing political advocacy for a long time, so I do ask politicians, do you have a GP? And a lot of them don't. They go at points of crisis, but they don't. So you haven't experienced good care. It's really hard to understand what good care is. So, but it needs to be communicated. And we're trying to do that with the general practice advocacy team that I'm on from the RACGP. So, yeah.
And Simon, have you got any comments on advocacy?
Yeah, so I think research, as Dr. Kim mentioned, is critical. So we've actually got a 3-year study happening at the moment around our care and the outcomes. We are actually documenting some of our outcomes, so that we can actually show the clinical outcomes. So I think that's really, really important, because we need to be telling the governments, this is the way, and showing them the savings. So if you were to work back also and show the actual savings that integrated lifestyle medicine, I did a calculation a few years ago and we saved about $15 million in just healthcare, just because of the integrated services that we had, and that's on the number of clients and the integration that we did. So some of those things potentially can actually help, because that's what politicians are after. They're after dollars and cents. How is this going to save? How is this going to be of benefit? And when you can show the outcomes and actually show savings, I think there's going to be opportunity to be able to advocate for that. But I'd also say just doing it. To be honest, it's on the ground. It's what people want. Like, we have people travelling from Sydney and Tamworth to get integrated care. So the more that people are doing it, and I love hearing about other centres like yours, Dr. Kim, that actually are doing it, the more that people actually do that on the ground, have great outcomes, it will eventually have an impact on the way things are done in the future. And so I think that that's the double-sided. We've got to advocate with the governments. We've also got to do it and do it really well, and showcase how beneficial it actually is.
Thank you. I have got one final question. It's from the audience, and it's to you, Kim. So it says as a solo GP, but I know that you work in a group practice, so I don't think you are a solo GP. So but do you upskill your nurses to attend to care plans and to ensure that communication between teams is enhanced?
So our nurses are integral to care. I don't think I could function without our nurses, because they've also have trained in separate skills with diabetes, and one of them, a diabetes nurse, actually sits on the national diabetes, a government organisation about diabetes, and look, they're trained in all areas, and they're in I would not function, because all our care plans and because I look after a lot of Indigenous patients as well. So I love our nurses. Like, we would love to have one nurse per doctor, which would be ideal. But you can't live in that world at the moment. We don't have it, but we.
And you mentioned that each patient is allocated a nurse, and how do you record that in your clinical software somewhere? Is that kind of
so the nurse, so the nurses, the patients know who their nurse is. So when because we have 3 registrars cycle through the practice, and they're there every 6 to 12 months, and the continuity is the nurse. So that's the connection.
Right.
So that and it's also the continuity is having always 2 doctors. So if I'm not there, there's a secondary doctor they see. So what I do, I work on Monday, Wednesday, Fridays. Their secondary doctor works on Tuesdays and Thursdays, so that there is continuity, and that's so important.
And you've got organisational continuity as well as some
absolutely. Our process is
and you've got continuity of records and all those things.
Oh, absolutely.
It's been a really fascinating discussion. I think we're pretty much out of time. I don't know if Jenny needs to hop back on, because people will probably have to do an evaluation. Is that right, Jenny?
Yes, I'm
sorry.
If everyone could just, at the end of, when I finish the webinar, the evaluation will automatically pop up, and we would love to get your feedback. This has been a fantastic discussion tonight, and thank you, Michelle. Thanks, Dr. Kim Liu, and thanks, Simon. I think that's all we need to say. So don't forget to fill out the evaluation, and I will see you at the next webinar. Good night.
Thanks so much, everybody.
Thanks so much, everybody. Bye.
Thank you.